Hey everyone, and welcome to this explainer. Today, we are cracking the code on the 5 major hepatotrophic viruses. That's hepatitis A, B, C, D, and E, and we're going to make their complex etiologies incredibly clear. Now, for those of you out there preparing for your USMLE or other medical licensing exams, you are in the exact right place. We are going to focus heavily on the high-yield clinical presentations, the essential serology, and those classic blue text board exam buzz points that you absolutely must know to crush your test. We're meticulously mapping out everything you need to master this topic, and our goal is to make sure you truly understand the underlying mechanisms, rather than just rotely memorizing a list of facts. Whether it's distinguishing transmission routes or identifying some really unique replication cycles, you're going to leave this explainer ready to tackle any related clinical vignette they throw at you. Here's our roadmap for today. We'll start with acute viral hepatitis, then move systematically through hepatitis A, hepatitis B, hepatitis C, hepatitis D, and finally hepatitis E.
All right, let's kick things off with Section 1, Acute Viral Hepatitis, the Clinical Foundation.
Let's ground our virology in a real-world clinical presentation, because before we look at the microscopic level, we need to know what viral hepatitis actually looks like when a patient walks into your clinic or the ER. Picture this. A middle-aged man, let's call him Matthew, presents with a 10-day history of low-grade fevers, general malaise, and upper abdominal pain. This instantly sets a clinical mystery tone, begging the question, which virus is attacking his liver? Well, here is a massive diagnostic buzz point for your exams. He returned 1 month beforehand from a holiday to Venezuela, which is a highly endemic area, and he didn't have any pre-travel vaccinations. His blood work shows an ALT of 100 and an AST of 120, alongside an elevated total bilirubin of 3 milligrams per deciliter. Notice that the ALT is markedly elevated. Why does this matter? Because in acute viral hepatitis, ALT is typically higher than AST. That is the exact opposite of what you'd see in alcoholic hepatitis, where your AST is usually double the ALT. Ultimately, serology revealed a positive IgM and IgG for hepatitis A. This is a classic presentation that perfectly illustrates how travel history, combined with those specific liver enzyme derangements, points us directly toward an acute hepatropic viral infection.
Now, before we narrow down the specific culprit in any generic case, we really have to recognize that acute viral hepatitis generally develops in 4 highly predictable clinical phases. First up is the incubation period. This is where the virus is multiplying, but symptoms are totally absent. Second is the pre-ecteric or prodromal phase. This features constitutional symptoms like profound fatigue, nausea, and notably, a sudden aversion to food and smoking. Mark that down, it's a classic high-yield board trivia point. Third is the icteric phase, where jaundice becomes physically apparent in the patient's skin and the whites of their eyes. Pay close attention here. Patients will develop dark-colored urine due to conjugated bilirubinuria. But why do they also develop pale or clay-colored stools? That's because of severe cholestasis, meaning a lack of bilirubin pigment successfully reaching the gut. Finally, we enter the post-icteric phase, which leads to gradual biochemical and clinical recovery over several weeks as those liver enzymes slowly find their way back to a normal baseline.
So, looking at an overview of the hepatitis viruses, we can distinguish these pathogens by their RNA or DNA genome and their transmission routes. If you're going to take a mental screenshot of any matrix for your exams, make it this one right here. Notice that hepatitis A, C, D, and E are all RNA viruses. Hepatitis B stands totally alone as the sole DNA virus, specifically a partially double-stranded DNA virus. Next, look at how they spread. Hepatitis A and E, the vowels, are transmitted primarily via the fecal-oral route, typically involving contaminated water or food. In contrast, hepatitis B, C, and D are transmitted parentally, percutaneously, or sexually. Finally, you absolutely must memorize the frequency of chronic liver disease here. Hepatitis A and E effectively never become chronic in healthy individuals. Meanwhile, hepatitis C carries a staggering 80% chronicity rate, making it a leading cause of chronic liver disease worldwide. Moving right along, Section 2, Hepatitis A, focusing on the fecal-oral route. Okay, so the actual culprit in Matthew's case is a small, non-enveloped RNA virus belonging to the Picornaviridae family, and it serves as our prototype for self-limiting viral hepatitis. Notice how the IgM, anti-HAV spike, perfectly aligns with the onset of clinical symptoms, while IgG eventually rises to persist for the remainder of the patient's life. When you're tasked with diagnosing an acute hepatitis A infection, you are specifically hunting for that serum IgM anti-HAV antibody. It peaks rapidly during the acute phase of the disease and stays elevated for about 3 to 6 months. Meanwhile, IgG anti-HAV begins to appear as the patient enters the recovery phase. You have to remember this crucial rule for your licensing exams. The presence of anti-HAV IgG in the absence of IgM strongly indicates a past cleared infection or a successful prior vaccination. That IgG is essentially a badge of honor, providing the patient with robust, long-term protective immunity against any future hepatitis A exposures. The really crucial takeaway for hepatitis A is that it simply does not become chronic, and there are virtually no lasting sequelae in healthy individuals. We generally see complete clinical and biochemical recovery by 6 months in almost all patients. But here's a highly testable blue text concept you need to understand. The hepatitis A virus is not directly cytopathic to the liver cells, meaning the virus itself isn't what's killing the tissue. The morphologic changes and severe hepatocyte injury you observe clinically are actually secondary to the host's own immunologic response. It's specifically the activation of the patient's CD8+ cytotoxic T lymphocytes and natural killer cells that target and destroy the infected liver cells, which then causes those huge transaminase elevations we see in the blood work.
Let's pivot to Section 3, Hepatitis B, our lone DNA virus.
We're now diving into the most thoroughly characterized and complex virus of the entire group, an absolute favorite topic for medical licensing exams. Breaking down the structure of this partially double-stranded DNA virus reveals the vital antigens that dictate exactly how we diagnose infections within the Hepataviridae family. Think of it like an onion. The outermost lipid bilayer is densely studded with the surface antigen, universally known as HBsAg. Deep inside, we find the icosahedral nucleocapsid, which is structurally composed of the core antigen, HBcAg. And you cannot forget the E antigen, HBeAg. This one is particularly unique because it's actually a secreted product of the viral nucleocapsid that bypasses assembly altogether and accumulates directly in the patient's serum as a soluble antigen. Understanding this architecture is totally non-negotiable. Each of these specific antigens and their corresponding host antibodies form the very foundation of the hepatitis B serology panels you'll be interpreting every single day on the wards. Now, its replication cycle is highly unique. Even though it's a DNA virus, it actually replicates via reverse transcription. It traverses from DNA to RNA and then back to DNA. Initially, the virus enters the hepatocyte by binding to the NTCP receptor. Once transported into the host nucleus, its partially double-stranded DNA gets converted into covalently closed circular DNA, or cccDNA. This highly stable episome then acts as a primary template for pregenomic RNA. Then, the virus's incredibly specialized DNA polymerase, which possesses crucial reverse transcriptase function, converts that newly formed RNA back into the viral DNA for packaging. Seeing this HIV-like reverse transcription happening inside a hepatotropic virus is a massive high-yield concept, mainly because it directly informs the pharmacological targets for a lot of our current antiviral therapies. Okay, listen up, because you have to master these serological markers, paying special attention to the window period where only IgM anti-HBc is detectable. Let's break this down carefully. HBsAg indicates a current active infection. If this specific marker persists for more than 6 months, boom, the patient has chronic hepatitis B. Anti-HBs is your definitive marker of immunity, arising either from natural recovery or from getting the hepatitis B vaccine. But there is a critical diagnostic gap, a so-called window period of several weeks where HBsAg has disappeared from the blood, but anti-HBs hasn't shown up yet because they're bound together tightly in circulating immune complexes. During this window, the literal only way to diagnose the acute infection is by detecting IgM anti-HBc. Lastly, if you see the presence of HBeAg, that indicates highly active viral replication and exceptionally high infectivity. It's also absolutely critical to remember that the profound immune response to hepatitis B can trigger some really severe extrahepatic issues. Up to 20% of individuals with chronic hepatitis B develop conditions like polyarteritis nodosa, membranous nephropathy, and membranoproliferative glomerulonephritis. These are classic board exam buzz points, but why do these occur? Well, it's because circulating immune complexes, mostly formed by HBsAg and its corresponding antibodies, literally deposit in the walls of affected organs and blood vessels. In the case of membranous nephropathy specifically, these immune complexes heavily deposit in the subepithelium of the glomerular basement membrane, leading to full-blown nephrotic syndrome. Understanding the pathophysiological link between the liver virus and these systemic immune complex diseases is a foundational concept. You just gotta know.
All right, on to Section 4, hepatitis C, and its exceptionally high chronic risk.
So, hepatitis C is notorious for being mostly asymptomatic initially, but it carries a massive risk for chronicity and operates quite a bit differently from hepatitis B. This concept of quasi-species is absolutely fascinating, and it directly explains why our immune system fails to clear the virus, and ultimately why we still lack an effective vaccine for it today. Hepatitis C is highly genetically unstable. Crucially, the virus's RNA polymerase lacks 3' to 5' exonuclease proofreading activity, meaning it has no spell check. Without this proofreading ability, there are exceptionally high mutation rates during replication. As a result, an infected person doesn't just carry one single viral clone, they carry a massive, genetically diverse swarm of mutant viruses called quasi-species. Because the viral antigens are constantly shifting and mutating by 1 to 2%, our anti-HCV IgG antibodies simply cannot keep up to bind and clear the infection. This persistent immune evasion is a classic, highly testable USMLE concept. When you're mapping the serology out, watch how serum HCV RNA behaves entirely differently depending on the patient's long-term immune response. HCV RNA is your absolute first detectable marker of infection, often appearing within just a few weeks of exposure. In stark contrast, anti-HCV antibodies might not become positive until 2 to 6 months after the initial event. Importantly, you must remember that a positive anti-HCV antibody test does not distinguish between a past successfully cleared infection and a current ongoing active infection. To determine the true clinical status, you must always look at the HCV RNA levels. If the viral RNA persists in the bloodstream beyond 4 to 6 months, you're definitively looking at chronic hepatitis C.
Contrasting these two clinical outcomes highlights a really stark and serious reality. 80% of those infected will progress to chronic liver disease. It's the 80-20 rule. Only about 20% of infected individuals actually manage to mount a sufficient immune response to spontaneously clear the acute infection. For the vast majority facing chronicity, the inflammatory cascade just continues quietly for decades. Over time, about 20% of those chronic carriers will eventually develop severe liver cirrhosis due to constant ongoing fibrosis. And from that established cirrhotic population, between 1 to 4% will subsequently develop hepatocellular carcinoma, or HCC. Understanding this slow, decades-long progression from an asymptomatic acute infection straight to end-stage liver disease and cancer underscores exactly why aggressive antiviral screening is so heavily prioritized in clinical practice today.
A major diagnostic buzzpoint for HCV is mixed cryoglobulinemia, a systemic vasculitis driven by circulating immune complexes. This is incredibly high yield for your medical licensing exams, so tune in. Cryoglobulins are pathological immunoglobulins that literally precipitate out of the blood serum at cold temperatures, specifically below 37 degrees Celsius, and then they redissolve when warmed up. In hepatitis C, these are usually IgM rheumatoid factor molecules that aggressively bind to anti-HCV IgG. They deposit heavily in the microvasculature, causing damage across multiple organ systems. Clinically, you need to watch for the classic presentation triad. Patients will present with palpable purpura on their lower extremities, debilitating arthralgias, and profound systemic weakness. This leukocytoclastic vasculitis is a textbook indicator of chronic hepatitis C that you simply cannot miss on a test. Next up, Section 5, hepatitis D, known as the defective virus. This pathogen is entirely unique because it operates as a defective viral parasite that requires an established host environment just to survive. HDV is fundamentally flawed and can only replicate and survive in the presence of the hepatitis B surface antigen. Belonging to the Delta Varidae genus, hepatitis D is a tiny, single-stranded circular RNA virus. However, its own genome doesn't code for the outer envelope proteins necessary for viral packaging and cellular exit. It actually operates like a molecular parasite, literally stealing the HBsAg provided by an active hepatitis B infection to use as its own lipoprotein envelope. Therefore, it is biologically impossible to contract hepatitis D on its own. It can only occur among patients who are concurrently infected with the hepatitis B virus. It's a uniquely dependent pathogen in human virology. The crucial point here is distinguishing the two distinct forms of infection, with superinfection being significantly more dangerous and highly prone to causing rapid cirrhosis. Co-infection happens when a patient is exposed to both HBE and HDV at the exact same time. This usually results in a severe acute hepatitis flare, but it's typically self-limited and the body generally clears both viruses simultaneously. Superinfection, on the other hand, is when a patient who is already a chronic hepatitis B carrier gets subsequently exposed to HDV. This presents as a massive, severe acute flare-up of their previously stable liver disease, and it carries a huge risk for progressing to cirrhosis and liver cancer. Remember this: superinfection is severe. That simple mnemonic will absolutely save you points on exam day.
Finally, Section 6, Hepatitis E, the waterborne mimic.
We're rounding out our explainer with a virus of the Hepathoviridae family that clinically mimics hepatitis A in a lot of critical ways. While it's largely waterborne and typically self-limiting, there are some incredibly important exceptions that define hepatitis E for your exams. Just like hepatitis A, it's primarily transmitted via the fecal-oral route, frequently spreading through contaminated drinking water in developing nations. However, in North America, sporadic cases often exhibit zoonotic spread, meaning it occurs from eating raw or undercooked meat from infected wild animals, like pigs, boars, or deer. And while it rarely causes chronic infection, doing so almost exclusively in severely immunocompromised hosts, there is one massively important USMLE buzz point you must memorize. Crucially, remember that while it's usually a mild illness, hepatitis E carries a staggering mortality rate due to fulminant hepatitis in pregnant women, particularly those in their third trimester. You will see that on a test.
So, with all these distinct transmission routes ranging from fecal-oral to parenteral, how can targeted global vaccination and sanitation efforts completely eradicate the most lethal forms of viral hepatitis? To conclude our explainer today, I want to leave you with this final thought on how we actively apply this complex virology to shape future global health initiatives. We've systematically mapped out how hepatitis A and E thrive on poor water sanitation, while hepatitis B, C, and D relentlessly exploit parenteral and sexual networks. Understanding these highly specific viral mechanisms, their unique replication cycles lacking proofreading, and their intricate serological markers isn't just about successfully passing your medical licensing exams. It's fundamentally about understanding the very biological targets we use every single day for life-saving vaccines, targeted antivirals, and major public health interventions. Keep reviewing those serology charts, master that window period, and I will see you in the next explainer.